the conclusion, the diagnostic confidence, how we convey that in the report, the recommendations, matching, critical findings, and incident norms. So they are all parts of our conclusion of the impression. So lexicon is the standard universal terminology which you use for the language which is used. So having a standard language will decrease the variation in reporting, increase the quality of information delivered. It will in turn lead to an increase in sensitivity, specificity, or accuracy of a particular test. And it will lead to easier mining of data for research. Like we have RedLab, MyRat, which are radiology specific lexicons. But in the impression part, you want to use a universal medical lexicon, which a medical graduate will easily understand, not something which a specialty specific lexicon like a pathologist will write in their reports, or we will write in our reports. But the impression part should be something which everybody can understand. And how we write it and what is the meaning of those words is covered in semantics. So our conclusion should have key findings, differential diagnosis, and recommendations. Everybody knows that. But we should not restate findings. We should not use excessive qualifying words, and we should not do hedging or vague recommendations tactics. So in the clinical sector, on a daily basis, you cannot be sure about the diagnosis or differential diagnosis of every case. It's not a black and white. There are multiple shades of gray in between. This is because there are limitations of the modality itself. The findings can be non-specific. There can be technical issues with this study, and the knowledge gap, which we have to acknowledge, because the indications, say, of PET-CT are rapidly expanding. We have no research, so it's very difficult to keep up with the knowledge which is rapidly evolving. So how do we convey the uncertainty? So when you are very confident about the diagnosis, you can use terms like this is findings are consistent with, compatible with, diagnostic, or there is scan evidence of, things like that. So at that end of the spectrum, most people will understand what you tend to convey. When you have slightly less certainty than this, so I may think that, okay, this finding is possibly something, this is probably something, this is suspicious of some finding, metastasis cannot be ruled out. So in this range, it's very difficult to clearly convey uncertainty, because different people may mean different and may understand it different from what we were trying to say. We'll discuss that further. Among negative findings, we may write that there is no evidence of something, there is no significant evidence of, no definite, no apparent evidence of, things like that. So again, mostly this is a clear area in which you say that there is a findings are not there. And in normal findings, we can write normal coverage within normal limits, no significant lesion detected. And in between here, something comes which is equivocal or indeterminate, which at times we have to use when you have no idea what the significance of this finding is. So I was reading one report of one of the patient who came to us for a follow-up scan. He had one of the scans done in MSKCC in USA. And at the end of the report, something very interesting was written, similar to this diagnostic certainty scale, which was typed and printed with the report. So this scale was made by a team from Harvard and in radiology, and they have defined the certainty or probability in terms of percentage, and the terminology has been defined. Say if you are thinking that if you are thinking that there is a very, very high probability of a particular disease, more than 90%, you say it's most likely. So between 75 to 90%, you say likely. 25 to 75%, you say may represent. So there may not be consensus on that, but they are using it, and this percentage kind of in an institution or in a work setting has been validated. I'll say that, okay, when I write most likely, that means that in 90% of the cases, that finding will be pathological, whatever I'm trying to say. In addition, they say that when you are 100% confident, you write the finding as diagnostic, or when a diagnosis is known, you can write that the findings are consistent, possibly suspicious, suggestive of. But we find ourselves writing these every now and then. So this was the MSKCC scale. Again, basically here we are saying that the top 10% indicate a very high probability, the lower 10 are unlikely, and in between we have the quartile, that 25%, 50%, and 75%. So you can use different words for that. But if I say, like, I was having a discussion with one of our endocrinologists last week. So when in our report they've written it's a likely parasitic adenoma. So they say that when you write likely, we are not sure whether it is there or not, unless you write directly that it is a parasitic adenoma. So, but I write likely that I feel that okay it is. So the terms can have different meanings for different peoples. So after the diagnostic certainty, we have to provide recommendations in our reports. There is a study which said that approximately 1/3 of PET-CT reports they advise additional imaging, and at times they may not have any additional impact on the patient's management. But we find ourselves again we have to recommend appropriate recommendation for furthering the patient's management. So we can have different words for recommendations, like we recommend a particular follow-up scan. We can say advised. We can say consider. So you can think when we recommend something, it is a relatively strong word as compared to advise and consider, which gives some opening into the physician to say, okay, I may do it, I may not do it. So it can have some medical legal implications also. Say some words like follow up as clinically indicated or something if clinically indicated. So there was a very sketching editorial in JNM more than 25 years back that the words if clinically indicated have been mentioned at the ends of most nuclear medicine reports in the US, and that it should not be done like that. I don't see that nowadays. Coming to the topic, so that is correlate clinically. So while we are reporting, we have limited access to clinical information and limited patient contact. And when the findings are not specific or not conclusive or are unexpected, at times we write correlate clinically. But if I review most radiology reports on nuclear medicine, maybe it's become a standard at the end. So in a study, they said that it means that everybody is of consensus that it means that correlate clinically means that the imaging findings should be interpreted in the context of clinical picture, or more information is needed to interpret the images. But 10% people believe that it is meaningless or it's a hedging attempt to shift responsibility and should be omitted. But specific correlation for specific findings based on the possibilities should be given. So that is a better way to go from correlate clinically to a specific clinical finding, because the patient has to be treated, not the finding itself. So hedging is the use of unclear or vague terms in the report, which do not clearly denote the uncertainty, and it is taken as an attempt to shift responsibility to the clinician. For example, we write cannot be excluded, may be of benefit, so is clinically warranted, things like that. So they are not very clear that what should be done. There is one component of the report which is the critical findings. So certain findings need to be communicated to the clinician on an urgent basis, and delay can lead to significant morbidity or mortality for the patient. For example, if I see a spinal cord compression, a new brain metastasis, or impended fracture, I think I highlight or write that separately in the impression, or it's better to communicate it directly to the referring physician and formulate a hospital policy for such findings. So we are finding more and more incidental omas, that's because we are doing whole body imagings out of away from the areas which are primarily affected. So there's possibility on us to answer whether the lesion is benign or malignant. Is it going to be clinically significant? And we have to avoid necessary workup. What to do? So we can have follow evidence-based recommendations and learn from our experience. So the end notes, again, they are very interesting notes at the end of PET-CT reports which we see. So this report is not valid for medical legal purpose, so this is in every report. So there are other things like all FDG lesions are not tumors, all tumors are not FDG evidence. I think this was made by someone who actually had to face a medical legal case. This report has been generated using software. Please contact the website for any errors. So the diagnostic certainty scale, again, I found in the notes of a report from US. So to summarize, we have to make a correct, concise, clear, confident, and reproducible report. We should use standard medical lexicon and structured format. So technical terms have to be used in the body part of the report, while more universal. I want to invite you all to, we are conducting a CME in pediatric nuclear medicine in October, and the next ANMPICON is again, we are conducting that in PGM of Chandigarh. Thank you very much.
Thank you, Dr. Harlan sir, for this illuminating talk today. I feel proud to be chairing a session in which you are a speaker. So, in the end, we can conclude that just describing a finding in a report doesn't finish our job. We also have to apply our minds and have to find the clinical significance of that finding, and also we have to give actionable points in the report on which the referring doctor can act.
Since this session is for students, I would like to reiterate the fact, and I keep telling this to my students, we are nuclear medicine. That's the reason why we say that time and again, the talk that our speakers have so basically given to us. Take home message that I want to tell, that we need to go back and take a history of the patients and the response, that criteria that we have just read. Also, the communication is key. We need to communicate with the referring physician what they want. The question that the scan is being asked for. If we know these few things in mind, then our report will not be vague. This is what I think the speakers are basically, and also as a nuclear medicine physician, also our responsibility to educate them, like in the beginning, Dr. We can thank you, chairpersons.
I think the entire flow was fantastic. We started with, what the clinicians want from radiologists. I think a good endpoint would be what the radiologists want from the clinicians. If we do that histories properly, a lot of this clinical students, I think what we do at our three things. One is we have a very detailed order form in which the physician, for the ordering physicians, can check off any patient staging, biopsy done, whatever. Also have patient questionnaire which patients fill out even before they come and see me. And even despite that, if you have questions, your clinician
move on to our next session, which is on sentinel lymph node imaging and biopsy. I would like to welcome our chairperson for the session. Our first chairperson, it's an honor for me to welcome our first chairperson. He's the driving force of oncology and personally for me as well. Chairperson, Max Oncology, Max Institute of Cancer Care, Dr. Harit Chaturvedi. Our next chairperson is the lady running the show at B.L. Kapoor Hospital, Nuclear Medicine Department, Senior Director Dr. Alka Kumar. Third chairperson is Dr. Manishi L. Narayan, Professor and Head of Department of Nuclear Medicine at AIIMS Rishikesh. Team Amrita has been setting up the protocols, leading workshops for sentinel lymph node imaging for all of us. First speaker is Dr. P. Shanmuga Sundaram for the sentinel lymph node imaging for head and neck tumors. So please.
I shall be discussing in the next 15 minutes the most relevant practical tips how to perform sentinel imaging in head and neck tumors. So as all of us know, the sentinel node is the first draining lymph node. And if we can prove that this harbors malignancy, then we can take the ensuing lymph nodal basis or basin as metastasis. So the sentinel node imaging and biopsy facilitates better sampling, number one, and also it avoids unnecessary diagnostic lymph nodal dissection procedures. So in that aspect, we know that neither the clinical examination nor the imaging is reliable in nodal staging, and ultimately the biopsy is the most crucial, and the biopsy can be further facilitated by the sentinel lymph node biopsy. So coming to the head and neck tumor sentinel lymph node imaging, we can either use blue dye or we use sentinel lymph node scintigraphy and probing. Although these two procedures are used combined or separately in other sites, for head and neck, we always prefer the sentinel lymph node scintigraphy and probing. So what are the challenges that we come across in the sentinel lymph node scintigraphy as far as head and neck sites are concerned? The number one, the nodes are very small. It can be as small as less than 3 millimeters. So probing can be difficult. You can have ambiguous lymphatic drainage. So you can have discordant sites. You can have multiple lymph nodes and multiple levels. So we need to have a SPECT CT so that we know exactly the depth at which the lymph nodes are present. Then another important practical problem is that it is too close to the primary. So again, probing can be difficult. And timing of the injection and imaging, both are very important in sentinel lymph node imaging and biopsy. Coming to the radiopharmaceutical, the practical tip is always use filtered sulfur chloride, or it can also be nanochloride. When you use filtered sulfur chloride, you need to ensure that the amount of radioactivity added to the preparation should be specific. For example, if you want to have 1 millicurie of filtered sulfur chloride, you are going to use at least 10 millicurie of normal sulfur chloride, so that when you filter it using the 0.22 micron Villex filter, you get at least 1 millicurie of filtered sulfur chloride. And filtered sulfur chloride is always preferred for head and neck sentinel imaging. The volume and dose. So this is again very relevant. Although variable people or variable volumes are being used, it is ideal to have lesser volume, say as less as 0.1 millicurie, 0.1 ml, and radioactivity even 0.4 millicurie is enough for a sentinel biopsy and during probing. So some of the practical tips for the injection. The peritumoral injections are always suggested. So you need to have a peritumoral injection for all the head and neck sentinel lymph node imaging, and imaging has to be started immediately. So this is again another important point. Majority of the time we cannot even do a dynamic study. You will most of the time you will do a static imaging, and this static imaging includes always the right lateral or left lateral depending on the site of the primary, but it also needs to be supplanted with an anterior image, because majority of the time you can have contralateral lymph nodes, and all those skin markings I have made, to have SPECT CT not be necessary. So this is a classical image which you can see right lateral, the primary tumor, first level sentinel lymph clearly seen within the 5 minutes of the post injection static image. But when you are doing anterior image, then you are also able to see the contralateral image, and you can also see as close to the imaging as much as possible. So the contralateral lymph node. So you see that right lateral 5 minutes is clearly showing the ipsilateral lymph node, but anterior image shows another contralateral imaging, another contralateral lymph node immediately within the next 5 minutes. So both needs to be. So when you have the SPECT CT, again it becomes much easier. So small lymph node also can be very clearly shown, and this gives a lot of confidence for the surgeon how to approach the lymph node and how to remove it using the. So some of the fallacies that can be obviated by taking care of the procedure, one is we need to give very clear-cut instruction to the patient what actually we are going to do, how we are going to do, and what is expected from the patient. For example, a simple instruction to the patient that continuous spitting out of the saliva can avoid the saliva contamination. And injections, again, as I told, peritumoral injection, ideally 4 injections, but it need not be always 4. Even a single injection or 2 injections can be more than enough, and we need to take care of the friability of these primaries. So primaries are small, number 1. Number 2, it can be friable. So when during the injection, if you don't take care of the injection, there can be significant spillage of the radioactivity into the oral cavity, thereby saliva gets contaminated. So these things are to be taken care during the injection. Coming to the timing of the surgery, it's again very important. Timing of injection, timing of imaging, and timing of surgery has to be coordinated to the best possible way, because we want to inject the patient just before probing, meaning you are planning the surgery half an hour later or 45 minutes later, means this is the time when you are injecting. Imaging should be instantaneous. Then you mark the first and second levels of lymph nodes. Otherwise, it will further move on. The radioactivity is going to move on further to the subsequent levels of lymph nodes, confusing both the imaging person and also the surgeon. So the timing and coordination is very, very important. Coming to the probing, so what is our role and how to work with the surgeon, especially in the initial period. So this probing should be done normally after primary excision. This is slightly different from what others preach. Normally people, what they say is you remove the node, sentinel lymph node, send it for the frozen, and during the frozen report, you can do the excision of the primary, but probably to avoid the crosstalk between the primary and the sentinel lymph node, it is better to do, if possible, the primary excision, that is excision of the primary tumor, then the probing. So that is one point. The second one is always you should know when you are going to do the imaging and when you are going to do the probing of the sentinel lymph node. And during the probing, this is the most important criteria. So how to identify the lymph nodes? There should be at least 8 to 10 times the radioactivity counts when compared to the background. So this has to be kept in our mind, and as we saw, we should do the prior imaging. For example, for breast imaging, for breast sentinel, you need not even do a prior imaging, because when you do a peritumoral or the oroputaneous with the areolar junction injection, then you know that it is going to be only axillary. But in head and neck, it is always important imaging. Without imaging, if we start probing, we may have multiple levels of lymph nodes being probed and being excised out. So I just wanted to discuss for 2 minutes our study which we did in Eden, just to bring out some of the important points, the relevance of our study, the relevance of our frozen section, and the relevance of the results what we got out of this. So in this study, we had two arms. One was the frozen section, different cytology. Based on that, if it is positive, patient will go for neck dissection. The other one is arm two, where in spite of whatever be the results, patient will go for a neck dissection. And these two were compared. And these patients had the frozen followed by this real step section of the sample, then also ILC. So this is very important. Even the literature says the occult metastasis in early sentinel or early carcinoma of the tongue, the sentinel node positivity is less than 30. This methodologies are the frozen a lot. And also communicate always prefer the section as not patients. Lymph node findings.
You guys talk
You can what I think something and
sorry, that was being this. That's the first Indian. Work early oral cancer. Extensive imaging worker. These modalities probably